sort of have an advocate for both positions. The first speaker will be Dr. Adashi, who's the former Dean of Medicine and Biological Sciences at Brown University in Providence, Rhode Island, and many, many other titles, but well known as a very articulate and intelligent speaker, and in my life stands out as the fellow who supervised my reproductive endocrine board, so luckily I passed.
Thank you very much, David, and good afternoon, everybody. As was already suggested, there's likely going to be less in the way of fireworks today between myself and my distinguished opponent. I left my duel pistol at home, and I have it on good authority that he did the same.
Don't count on it.
There you go. The reason for me making this preliminary statement has to do with my assessment, as Dr. Barad already suggested, that myself and my distinguished opponent are in general agreement on the answer here. It would be difficult for somebody like myself to defend the position that would be opposite to my opponent's position. It would be difficult to discard patient autonomy in favor of provider paternalism. That's something I've been very involved with for a long time. It would be very difficult for me to even come up with reasonable arguments that would somehow justify such a position. With that in mind, I plan to just say a few things about the case, and then with your permission, I'd like to take this opportunity to discuss with you the evolution, the very gradual and maybe the very early stage of evolution of the concepts we have about motherhood in general and perhaps parenthood more in particular. After all, this case, among the issues it raises, is the distinction between genetic motherhood and gestational motherhood. And part of the thinking and deliberations on the part of the patient as to which route she should go has a great deal to do with whether or not she is very keen on genetic motherhood, which is still, in all likelihood, the prevalent position, and how happy could she be, would she be, with gestational motherhood, wherein the egg was donated by a donor. As I will try to illustrate to you, there are cracks forming in this historic allegiance to genetic parenthood. I don't know if it will ever be completely discounted or altered, but I sense a certain early form of evolution here, and I thought I would share it with you as part of this presentation. Viewed dispassionately, the hypothetical patient in question is obviously approaching a challenging segment of the reproductive lifespan. A narrowing range of potential therapeutic options can and must be considered at this juncture. Now, over 42 years of age and or featuring basal circulating levels of LH, of FSH, of 15 to 20 milliards per mil. This patient can be safely assumed to manifest other markers of diminishing reproductive function. A listing of such potential markers has been carefully delineated by the practice committee of the ASRM. Viewed in this light, this patient may also feature low day 2 basal serum estradiol levels, potentially low serum AMH levels, low antral follicle count, and quite possibly premature luteinization. Should superovulation be undertaken either in the context of IUI or in the context of IVF? It might in fact be safe to assume that evidence of premature luteinization may have already been encountered in the past, and that piece of history may well have been conveyed to the providers in some of the early encounters. Given these conjectures, the patient under discussion would in principle have to settle on one of the following therapeutic options: superovulation with IUI, IVF, or egg donation. The evidence is quite clear as to the relative inutility of superovulation with IUI. The live birth percentage rate per treatment cycle for this therapeutic modality being uniformly inferior to those accomplishable via IVF at virtually any age. On the other hand, carefully managed IVF remains a viable option in women of advanced age, as shown repeatedly, among others, by my distinguished opponent and his colleagues. According to some, the IVF age cutoff might in fact be 45 years of age, and if you come from Australia, that might be one point of view. Yet others reported the outcomes of IVF in women 45 years and older. In the words of the authors, autologous IVF in women aged 45 with acceptable ovarian reserve is limited in its success, though not futile. Patients older than 46 years of age should be counseled appropriately that live birth is highly unlikely. Which brings us to the egg donation option, which can certainly be counted on to deliver substantially improved live birth percentage rates per treatment cycle. Though incompatible with genetic motherhood, egg donation is noteworthy for assuring gestational motherhood, the importance of which must not be discounted. We will, as we must, I think, return to this point a little bit later, in that the decision between IVF and egg donation is bound to be influenced by the precept of genetic motherhood. Ignoring this point and what I believe is its ever-evolving nature would fail to do justice to this debate. An additional question raised by the IVF option in the patient under discussion has to do with the potential violation of the notion of futility. As articulated by the Ethics Committee of the American Society for Reproductive Medicine. Therein, futility is defined as success rates that are equal to or inferior to 1% of live birth per treatment cycle. Very poor prognosis, in contrast, is defined as a success rate ranging between 1 and 5% of live birth per treatment cycle. Neither definition need presently apply to the conduct of IVF in patients past the age of 40, in whom customized patient-specific regimens will have been applied. One obvious exception to this statement is, of course, the documentation of a menopausal state, wherein the basal circulating levels of FSH equal or exceed 40 milliAUs per mil. One would be hard-pressed to fault a provider who, upon facing the patient in question, proceeded to discuss all the available therapeutic options, inclusive of the possibility of egg donation. The patient is, after all, entitled to all the facts surrounding her case, just as she is entitled to decide on the course of action she wishes to pursue. There is no debate here. It is really all about patient autonomy. In this respect, as I indicated earlier, I'm in complete agreement with my distinguished opponent on this score. In other words, there exists no magical cutoff which marks a woman who is older than 42 years of age and or features basal circulating levels of FSH between 50 and 20 milliAUs per mil. The decision as to how to proceed, given the appropriate information, is the patient's and the patient's alone. When it comes to the question of autonomy, there are multiple reasons why the patient under discussion must have the final say on the therapeutic plan she wishes to pursue. Autonomy refers to the capacities for self-governance, self-determination, and self-authorization. It requires that patients understand their options, reflect on their values and desires, and then choose and act on the basis of those values. It follows that autonomy, often an element, by the way, of the Hippocratic Oath, trumps paternalism any day. Fortunately, the principle of respect for patient autonomy has been, and thankfully continues to be, on the ascendancy. Failure to grasp this trend harks back to a paternalistic era and to a time long and indeed rightly gone. This conversation would not be complete, as I suggested earlier, without some mention of the ongoing dynamic evolution of the notion of parenthood. It is here really that the notion of genetic ancestry reigns supreme. The evolution that I'm referring to is driven in part by novel parental constructs attributable to breakthroughs such as mitochondrial replacement therapy, so-called three-parent babies, stem cell-derived human gametes, so-called artificial gametes, which are going to give rise to multiple possibilities. This latter possibility in particular, yet to be broadly realized, may expand parenting platforms to include single parental constellation, same-sex constellations, and perhaps even multiplex parenthoods. It might also make possible the notion of post-menopausal motherhood, which could come to the fore, replete with the uncertainty, of course, of rearing children subject to premature orphanhood unless our lifespan is extended, as was so kindly suggested to us by one of our earlier speakers. These heretofore largely hypothetical scenarios, should they come to pass, may, quote, democratize human reproduction, as some have suggested. Capturing the essence of this dynamic scene, the Nuffield Council on Bioethics in the UK, in a recent background paper, denominated this new steady state as the, quote, degeneticization of human reproduction. That is to say, the potential of moving away from the predominance of genetic parenthood. Apart and distinct from the role of recent breakthroughs, the evolution of the notion of parenthood has also been advanced by feminist ethicists. Much of this material can be found in the book titled Family Making. A lay version of the same is captured in Carl Zimmer's bestseller, which many of you may be familiar with, titled, quote, She Has Her Mother's Laugh, which of course refers to the genetic construct of motherhood. As a general rule, this school of bioethics, by that I mean the feminist school of bioethics, regards what has been termed geneticism as social bias that compromises a woman's reproductive autonomy. Through it all, the common emerging theme is that the linkage of family making to genetic relatedness may be outdated, may be overvalued, in that it characterizes genetic ties as necessary and superior to both personal and family-related identities. According to this worldview, geneticism handicaps alternative nurturing options such as social parenting or other mothering, which could include embryo or, for that matter, child adoption. Professor Francois Baylis, a Canadian bioethicist and a vocal advocate of alternative parental constructs, minces no words when articulated some of these novel notions. Here are a few quote samples that perhaps are worth going over. I maintain, Professor Baylis offers, that there is no right to biological parenthood, nor to a so-called need for genetically related children. We ought not to pander to an acquired desire for genetic filiation, nor overvalue genetic kinship for family making. Professor Baylis goes on to say, I want to live in a world in which children are cherished and benefit from unconditional love from their parents. Overvaluing the importance of genetic links between those who care for children and the children who receive this care sets up an inappropriate a priori condition for parental love and further entrenches narrow understandings about legitimate family making. She goes on to say, while I recognize that some people have a strong desire for genetically related children, it is important we not mistake wants or needs for rights. As you have all undoubtedly concluded by now, it does not get any more explicit than that, and Professor Baylis has never been known to hold back punches. In summary then, there does not exist a magic cutoff point along the reproductive path beyond which egg donation is and must be called for. The sole responsibility of the provider is to ensure that the relevant information has been communicated. What to do next, if anything, is exclusively the prerogative of the patient. Autonomy may also be construed as the right to know, because appropriate decision-making, or more classically, informed consent, requires the full disclosure of the risks and the benefits. Not surprisingly, patient autonomy is listed as the very first ethical principle articulated by the Beecham-Childress textbook, which we mentioned yesterday, I believe, titled The Principles of Biomedical Ethics. It is a principle we dare not, should not violate. Thank you very much.